Okay, well, I'd like to welcome our panel for this next Q&A. I want to thank Dr. Cheifetz, Kochar, and Kroshinsky for really three outstanding lectures. Let's start with Adam first. And so one question here is, what are your target drug concentrations for infliximab for fistulizing Crohn's, and are your listed levels adequate?
So it's a great question. There is some cross-sectional data that suggests patients with perianal disease may require higher drug concentrations. There are association studies, and one came out of Miami suggested even as high as 20. So I will push them higher, but realistically in practice, most of my patients don't require more than the 10 to 15, which I aim for.
Okay, let me ask you another quick one here. So when during induction do you obtain drug monitoring? Immediately before the next infusion?
Yes. So right now we're running a randomized controlled trial. So we're actually checking, part of this trial, one of the groups checks at week 2, and then prior to the 0 to 6 third dose, and we'll go from there. In practice, clinically, I am often checking now, honestly, at week 6, and then prior to the first maintenance dosing.
Okay, great. Thank you. So Bharti, if a patient is in clinical and endoscopic remission on an immunomodulator monotherapy in someone older than 60, are you considering switching to a biologic specifically due to the increased lymphoma risk?
That's a great question. I think it's something we encounter a lot in clinical practice. Quite frankly, there's no right answer. We just don't have the data to really, know what the right answer is. We do know that lymphoma risk really takes off in the 40s and probably peaks in the 60s or 70s. But there's also something to be said about survivor bias, as in, if they've been on this thiopurine for 40 years and haven't had a lymphoma, the chance that they're going to have a new lymphoma might be lower. So I also worry a lot more about the zoster risk and the other infection risks with thiopurines. So what I'll tell my patients is, because I've also gotten into trouble just switching for the sake of switching. And so, what I'll tell them is if there's anything small, minor, if we find like an endoscopic patch of disease, this is a good reason to get on a selective biologic agent, which has a much more favorable safety profile longitudinally, and then start weaning off of your thiopurine. I will do this in a level guided way too. I'll always check a level when I meet an older patient with a thiopurine level when I meet an older patient who's on thiopurine monotherapy, because oftentimes their metabolites might be very, very low. And so you wonder if they're not really deriving much therapeutic benefit from this anyway. So it is a little bit of a data-free zone and a great question.
Okay, great. Thank you. So Dr. Kroshinsky, can you comment on hidradenitis suppurativa? How often do you see this lesion in IBD, and what's the management for severe forms, especially if they don't respond to IBD biologics?
Yeah, so this is an area that finally I think is getting a lot more attention in dermatology from a management standpoint. It's one of the worst diseases that we encounter, and I think up until recently, we haven't had great strategies for managing. I think we see it often misdiagnosed as like furuncles or abscesses. So I would encourage people to either inquire or examine the axilla, the groin, the mons pubis region, sometimes even behind the ears. The symmetry is going to be a clue. If you look for comedones, which are basically like blackheads, that's also another clue for early disease. The key here is to try to diagnose and get management started as soon as possible. Late disease, fistulas, sinus tracts, scarring, very hard to gain control without surgical intervention at that point. And so in the early phases, we try topical antimicrobials in the form of like washes. Laser hair removal is really quite helpful to destroy the follicular unit before you get the deeper involvement. In the setting of IBD and diagnosis of HS, it is often covered by insurance. So I would refer people to an academic center that does that. They often have ways of getting that covered. And then we sort of escalate from there. I briefly showed you that chart, but you could spend a whole, hour and a half on that alone. And so we really rely on a multi-pronged approach to managing inflammation, bacterial colonization, and then suppression of inflammation. But again, if you can destroy that follicular unit early, you're preventing significant progression. Once you have someone with long-standing scarring disease, think about a surgical excision and grafting.
Okay, great. Thank you. Adam, does antibody to one TNF agent contradict use of another TNF agent?
No, absolutely not. No, in fact, I would say, what we'll often see is someone's doing great on an anti-TNF for a bit, they lose response, and someone finally checks drug concentrations. They have high levels of antibodies to one anti-TNF. The fact is if you transition them to another anti-TNF, they have like a 90% chance of doing great, at least initially. So what we do know is that if you develop antibodies to one anti-TNF, you are much more likely to develop antibodies to a second anti-TNF. So you should be very cognizant about doing, I would argue, proactive therapeutic drug monitoring, and strongly also consider the use of a concomitant immunomodulator.
Okay, great. Dr. Kochar, I wonder if you might just give sort of a kind of a roadmap for how you approach a new onset, new Crohn's diagnosis disease at age 74.
Good question. I would say the same way that you would approach it if the patient is 34. And so, you want to do a complete staging, you want to look for extraintestinal manifestations, you want to see if there's, particular aspects about the disease or the patient that would lead you for one particular therapeutic agent over the other. So for example, do they have an inflammatory arthritis or an iritis or something else that might want you to pick an agent that would cover the joints or the eyes better, or, would they benefit from a very selective biologic agent? And so, what I would discourage you from doing is saying, this person's older, let's just get them on the safest medication we have, which is, by the way, Entyvio, we think. And so let's just put them on that. Because that's actually where you could, I think, do the most harm. Picking that first biologic agent becomes very important. We know now that the first biologic agent is very much, the best biologic agent if you're able to appropriately choose. And since we have no other way other than our clinical acumen, I would say, do the same things that you would do for your 34-year-old. Of course, you do want to assess functional status, but also remember that sometimes it's those who are the most debilitated by their IBD that could benefit from effective upfront treatment. And so, in-depth conversations are important at all ages, but especially at older ages. So it takes time, but I don't think it should be different than your younger patient.
Great, that's terrific. So Dr. Kroshinsky, our IBD patients on biologic therapies often complain of hair thinning, hair loss, and what are your suggestions for what to do in these cases as far as workup and treatment, or do they just need to go to derm every time?
Not necessarily. I think, the easiest first step, it's usually not a physiologic reason, meaning like it's not nutritional, it's not thyroid, it's not anemia, but, easy things to check. So get those labs, low-hanging fruit, you're probably already checking them. Get a sense of history. I mean, if I would do first a really good exam, we divide alopecia into scarring and non-scarring. So if you look at the scalp and it's just sort of like thinned, versus you see actual, like almost like it looks like someone took a steamroller and you're looking at shiny skin with no hair follicles, that's more scarring. If you see like redness, flaking, inflammation, something along those lines, it looks angry, send those folks to derm. We have to get those under control very quickly. The non-scarring alopecias, we talked a little bit about alopecia areata, that you'll recognize, but the main one that I think we see, the main two that we would see in an IBD population are going to be telogen effluvium, which is a post sort of physiological or psychological stress related shedding. And people will tell you their hair is falling out in clumps, like diffusely, they're seeing a ton in the shower. It's different from before. Those folks, get a sense of 4 to 6 months earlier, did they have some hospitalization? Did they have a major flare? Were they ill? Something going on at home, significant post sort of pregnancy, we see it, or actually post sort of delivery or post stopping breastfeeding, all those things will be triggers. In that case, tincture of thyme, if they're really bothered by it, you can do oral minoxidil, probably for like the fastest control. The other thing you want to ask about is sort of family history, get a sense if it's just a receding hairline. That's going to be more androgenetic, or if you see like a patch in the back, particularly in women where we wouldn't expect to see that, that's more sort of like a hormonal genetic loss. And those folks send to us as well. It can be very distressing for patients to have hair loss. And so I think a lot of it you can manage, but certain groups would benefit from referral and more rapid intervention.
Okay, great. So Adam, a couple of quick questions here. What is the definition of a high level adalimumab in reactive testing algorithm?
So I aim for greater than 10 to 15 at least before giving up on, honestly, either infliximab or adalimumab. If it's, because if you say it's adequate, forget high, if it's adequate and they're not responding, you're basically saying they are a mechanistic non-responder or loss of responder to TNF, so none of the TNFs are going to work. So I push it to at least, honestly, 15. And I think most sort of people would agree with that.
Okay, and then I guess a theoretical question, why is it better to increase frequency rather than drug dose?
Yeah, it's actually not theoretical. It is, one, I would tell you, PK-wise, it makes more sense. So if you look at any of the PK dashboards, or if if you're smarter than I and you can actually figure out PK and those types of things, the shortening the interval does much more than increasing the dose. So if you double the dose, say 5 mg per kg to 10 mg per kg every 8 weeks, that's more akin to 5 mg per kg every 6 weeks. Plus, that way you don't end up with as big a peak. And it definitely makes more sense. It's a little bit sometimes difficult to convince your patient to come in more frequently, but so we do end up doing both, but I'm a bigger believer in the shortening the interval.
And another just logistical question here, does the insurance usually cover therapeutic drug monitoring, or do you have to send out specimens to tertiary labs?
So, I mean, I can tell you the way it works in our institution, if I send it through our system, it ends up going out to Quest, which, 9 times out of 10 is fine. And I've not had a patient get a bill for that. Our research is done with Prometheus, and I still will send to them, but there definitely is a potential out-of-pocket cost to the patient, and it's nearly impossible ahead of time to know whether the insurance is going to cover it or not and how much the out-of-pocket cost is. I think, honestly, that to me is one of the biggest sort of detriments or problems we have with TDM.
Okay, Dr. Kochar, does the natural history of IBD differ in the older adult in terms of anything, in terms of particularly extraintestinal manifestations?
Not that we think of. We have a few large cohorts that we're looking at when we say this, but again, it's a little bit of a data-free zone because a lot of studies exclude older patients. And so when you account for disease duration, we don't necessarily think that there's a big difference in the natural history. And I think some of the more traditional notions that older patients might have a milder course of disease could stem from the fact that older patients might not have had either 20 or 40 years to develop that robust aggressive disease that we sometimes see in younger people. We are, seeing in all centers kind of the older person, the 70-year-old and the 80-year-old that's coming in with really, really active disease. And we do know that, for some people, aging is an inflammatory process. What we're not able to identify is who those people are. There are certainly other people who do have naturally milder disease as they age, and their IBD becomes less clinically significant and almost absent. And so if we can find a way of knowing who those people are when they're 60, of course, it would make life easier. But I wouldn't anticipate a milder natural history.
Okay, great. Thank you. Dr. Kroshinsky, this question, I'm not quite exactly sure what they're asking, but they're asking about, I think it's about the cutaneous manifestations of IBD and like how often they do follow the course of IBD and how often they don't. And if there's certain skin diseases that you might put into each of those categories.
I would say most often they don't. They're doing their own thing. Erythema nodosum might be the exception. You see that kind of flare up. You might want to think about revisiting the status of the bowel disease. But the majority of them do their own thing. So you could be in great shape from a gut standpoint, and the skin is terrible, or vice versa. So I tend to sort of take everything just at face value. I don't like to change the GI regimen if I can avoid it. And certainly I try not to stop anything if I can avoid it. Fortunately, most of the cutaneous conditions have alternate therapeutics that we can add. I think certainly if you have a TNF-alpha induced psoriasis, that can be more challenging. We still really try to push as far as we can to get through that if possible. But ultimately, if you fail adjunctive therapy, if you fail switching to a similar agent or another agent in the same class, then unfortunately we do have to move on. But we can usually kick that can down the curb for many months before that happens.
Okay, perfect. So Dr. Cheifetz, actually, so there's a clarification on that earlier question about what is your definition of high-level antibody formation?
Okay. So high-level antibody formation, this is an excellent question. And here really assay matters. So typically, when I say, what test do you use? I said I usually use Prometheus. If there's any issues, I'll send to Quest. The drug concentration correlates pretty well between them, but you're going to use an assay, follow that same assay throughout. But drug concentration, which is by far the most important value, is okay with most assays. Where I think people get tripped up is with exactly this, is with the antibody measurements and levels, and they're very different between assays. This is, again, typically where I'll use Prometheus assay. We have a study, and others have looked at it, where honestly, in our study, it was a level of antibodies greater than 8 were considered to be high. In clinical practice, I've overcome levels of greater than 20 if necessary. And where I really see issues are with something like a LabCorp or a Quest or even a Mayo. These assays, their antibody tests have not been validated, and they'll say, okay, greater than this is high, greater than this, less than this is low, but it really isn't. And we'll see people come to see me. They'll have an infliximab concentration of 10, which is great, but their antibodies were 700. Somebody stopped the drug, they flared. And in that case, the 700, honestly, if you divide it by 1,000, that's really what the level was. So that's where things can get very confusing, and really focus on the drug concentration. And again, if necessary, if you do see that, utilize an assay where the antibody levels have been validated.
Okay, wonderful. Dr. Kochar, I know this is a follow-up to that 74-year-old question, and this may be theoretical, I don't know, but so let's say that the 74-year-old Crohn's patient now is in a war zone, doesn't have access to IVs. What would you start with therapy in that case?
Well, I mean, maybe it is a theoretical question, but maybe it's not. And if it's not, my immediate response would be they have a lot bigger fish to fry right now than which IBD treatment. But maybe the question's really getting at, what oral options would you consider? So right now in the United States, we don't have S1P receptor modulators approved for Crohn's disease, but perhaps for mild to moderate colonic Crohn's disease, that would be a reasonable thing to consider. Could be quite effective. And then certainly JAK inhibitors, I always get the question of, would you use a JAK inhibitor in a 70-year-old? And so that's perhaps what this question is really getting at. Remembering that the vast majority of older adults, especially if we define them as 60 and older, are actually, not multimorbid and may not have cardiovascular comorbidities. JAK inhibitors would be quite reasonable to use. So just because you're over 50 does not mean that you're at higher risk for having a cardiovascular event with JAK inhibitors or for malignancy. The people in the oral surveillance trial were over 50 with one additional cardiovascular risk factor. So in our practice, we do calculate the ASCVD score, and if it's over 10% for the older person, then it's a little bit uncomfortable to start a JAK inhibitor, but for the vast majority of older people, it tends not to be. And so, with some in-depth conversation and counseling, we start JAK inhibitors on older people all the time if their disease severity merited it. Of course, if they're in a war zone, the other thing to consider is, geographically where they are. And, it's very important to think about like what they can get locally. And so I have had patients that have started on thiopurine monotherapy because they live in a country where they do not have all of the treatments that we do have. And so while I do counsel people that thiopurine monotherapy is not as appropriate in the modern era, like if you need to do it for local availability, then that's what you have.
Okay, great. Thank you. Adam, so there's a question here on what is your go-to immunomodulator when switching to a different anti-TNF after becoming antibody positive with another TNF?
Great question. Not a lot of evidence for this. So I would argue, I would think azathioprine and 6-MP pound for pound do a better job with suppressing immunogenicity, but methotrexate is much easier to use. So in general, I've tended to go with methotrexate about 15 milligrams a week with obviously folic acid until I get to the drug concentrations I want, and then I'll pull it off. Almost always in my patients, immunomodulator use is for no more than 6 months, maybe a year. Just again, I think the best data is for the azathioprine. Just a little bit more cumbersome to use with the TPMT testing and all that jazz.
Okay, great. And another kind of dose question here. So what is your maximum dose and interval with adalimumab and infliximab? Do you often combine with methotrexate?
So, the FDA has their own dosing, so I'll start with that, but I have patients on 80 milligrams a week of adalimumab, and honestly, we've had people as high as 15 mg per kg every 3 to 4 weeks of infliximab until their clearance improved, and they were able to space them out and decrease them a little bit. It's all drug concentration, right? So it sounds scary, but they're clearing the drug quickly, so you're giving them the right amount of drug. Just to bring it back to dermatology a little bit, we have one of our dermatologists here is actually doing a lot of TDM, and she finds, particularly for hidradenitis, these people require almost like superhuman doses of the anti-TNF therapies.
I would say I have almost nobody that's getting less frequent than Q4 weeks.
Yeah.
Maxed out. Yep.
All right, there's one last quick question here about methotrexate. Do you give it orally or IM?
I just give it orally if I'm using it to suppress antibody formation. I think it's fine as long as their small bowel is not totally beat up and chewed up, and I think they can absorb it. It's just easier.
Okay, fantastic. So we've reached the end of our Q&A session. I want to thank Dr. Cheifetz, Kochar, and Kroshinsky for their time and their expertise. That was terrific. I'm sorry we didn't get quite to all the questions. If they have time, I'll ask the speakers if they can respond to you by text on the screen. But otherwise, thank you. So we'll take a 1-hour break here now. So we'll come back at 1:45 Eastern time. And we'll see you then.